PUK presents something like this: a crescent-shaped destructive inflammation of juxtalimbal corneal tissue associated with epithelial defect, presence of stromal inflammatory cells with progressive stromal degradation and thinning, and conjunctival, episcleral, and scleral inflammation may be present. And the patient would generally complain of foreign body sensation, severe pain, redness, tearing, and photophobia. And visual disturbances may be gradual or they may be sudden. If it is sudden, then you know that PUK has progressed. It is important to take a good systemic history, which includes the constitutional symptoms such as chills, fever, decreased appetite, weight loss, fatigue, because they will point towards the systemic issues. Apart from this, patients can have skin, respiratory, cardiac, or GIT disorders and can also have neurologic symptoms. And this occurs more in cases of rheumatoid arthritis, SLE, PAN, Wegener's granulomatosis, and relapsing polychondritis. So it is important to know the extent of ulceration, which could be both. One needs to know the circumferential as well as central, and grading. So if it is less than 25%, then it is grade 1, 25 to 50% is 2, and 50 to 75% is 3, and more than that is grade 4. Then again, it is important to know whether sclera is involved or not, which could be diffuse, nodal, or necrotizing, and necrotizing scleritis indicates the presence of systemic disease. So systemic evaluation is important because in collagen vascular disease, you may have lesions on the skin, face, trunk, joints, and extremities, and it is always better to have a rheumatologist or a clinical immunologist in your team. The most common cause of PUK in a study that we published a few years ago was infections in India. So I think that is very important to rule it out, and it could be due to bacteria, virus, acanthamoeba, amoeba, or fungus, and in our series it was due to bacteria. So it is important to rule out infections. Sometimes you may have immune related PUKs, but a super added bacterial infection on it. Then non-infectious could be because of Moran's ulcer, Tyrion's marginal degeneration, pellucid, blepharitis, neurotrophic or neuroparalytic due to rosacea, nutritional deficiencies, chemical injuries, trauma, and could be post-surgical. Then you can have cases with autoimmune disorders like Behçet's, and in these cases you may have episcleritis and scleritis, which may precede the onset of keratitis, and then other features like uveitis and retinal vasculitis. Moran's, of course, is diagnosis by exclusion, which will have undermined edge, which is irregularly scalloped, and the corneal damage is always more than obvious during the slit lamp microscopy. And then sometimes it can even heal on its own, so there could be reepithelialization, scarring, and vascularization. This is a case of Moran's in which there is thinning in one eye, and in the other eye, it's a malignant Moran's ulcer. Now, investigations for a case of PUK require microbiology workup, like I said, and lab investigations, which could include a complete blood count, urine analysis, creatinine, BUN, ESR. Rheumatoid factor is present in 80% of the cases of rheumatoid arthritis. Then ACE enzymes, which would be increased in sarcoidosis, anti-nuclear antibodies, anti-double stranded DNA, and anti-small nuclear ribonuclear proteins. Apart from this, ANCA should be done. You may also have to do complement C, 3, 4, anti-type 2 antibodies, hepatitis B antigen present in 40% of patients with PAN, and FTA ABS test for syphilis. Then imaging studies do have a role to play, such as X-ray chest and X-ray of the affected joints. And the treatment would depend upon the severity of the corneal disease and extent of extraocular disease. An important goal of medical therapy is to reduce inflammation. So if it is an infectious etiology, one has to give antibacterials, virals, and fungal agents. If it is immunological, then you start with topical steroids, taper it, and you can even stop it after using over months. Lubricants have to be given wherever there are altered tear film dynamics. Collagenase inhibitors can be given, such as topical 1% medroxyprogesterone in QID doses, topical 20% N-acetylcysteine again in QID doses, and cycloplegics, of course, may be given. Even if it is immunologically related, one can add a topical antibiotic because you don't want super added infection in these cases. Systemic collagenase inhibitors can be given, such as tetracycline 250 milligrams QID or doxycycline 100 milligrams BD for the initial 1 month. And immunosuppressive therapy has to be given if indicated. So you start with the systemic steroids, and systemic immunosuppressives can then be substituted if it doesn't get cured by systemic steroids alone. And topical steroids are generally not safe if the ulcer is deep or if there's an infiltrate present. Now, just to take you through the case examples, these are PUKs due to staph, where topical antibiotics were given, cefazolin and tobramycin, and here cefazolin and tobramycin with systemic antibiotics was given. Now, this was a PUK due to aspergillus keratitis, and this was due to herpes keratitis. Sometimes you can have, due to immunological mechanisms such as this, which after therapy has healed. So there's a step ladder, wonderful article from the LVPI group, which has given a step ladder pattern to manage the PUK. So in unilateral cases, less than 2 quadrants involvement, less than 50% thickness, one can give topical steroids and follow up these cases until healing occurs. And this is the way it heals if you give topical steroids. You may also give topical cyclosporin if the patient is steroid dependent and there's raise of intraocular pressure, and this is a case to show that. And sometimes you may have to combine both topical cyclosporin A and topical steroids, and it causes healing here. Now, systemic steroids, on the other hand, are indicated when there are bilateral cases, more than 2 quadrants of peripheral corneal involvement, more than 50% stromal lysis, and dose is prednisolone 1 to 1.5 milligram per kg body weight, and you have to follow up these patients over a prolonged period of time. Pulse therapy in the form of IV methylprednisolone again is given in bilateral cases where there's more extensive involvement, more than 3 quadrants with more than 50% stromal lysis. And you can combine this methylprednisolone with the cyclophosphamide in bilateral cases, one-eyed patients and more than 3 quadrants involvement, such as shown here with a desmetocele, and which is impending perforation. So these patients should, whenever you're starting immunosuppressive, it is best to do it with a rheumatologist and admit these patients preferably in the ward. You can't use systemic steroids for a prolonged period of time because of the obvious side effects. So you should know about systemic immunosuppressives, when to use, how to use, and what to use, and what can go wrong. So systemic immunomodulators, very beautiful algorithm which has been given by Dr. John Dart, my mentor at Moorfields. So these are the various agents which can be used, and the agents which are in the same color, try and never combine these agents because they have the same mechanism of action. So if you have to combine agents with different colors. So one can start with prednisolone and avoid mixing drugs in the same color groups. So start with prednisolone 80 milligrams daily, and start steroid sparing drug when you expect prolonged disease. So you can start cyclosporin A for patients less than 60 years and azathioprine, mycophenolate or cyclophosphamide in older patients. And this is the step ladder pattern which has been described by Dr. John Dart. So you start with Dapsone, go to methotrexate, then azathioprine, then cyclophosphamide, and then you can even start IV immunoglobulin if it doesn't respond. Combined drugs for resistant cases, and these are the doses of the various drugs which have been advocated. If you want, you can take a picture of it. I wouldn't be discussing the dosage of each. And this is how you withdraw them. So steroids would be tapered over a period of time. Cyclophosphamide, you will stop flush at 1 year. And azathioprine again is tapered, and cyclosporin can also be tapered. And wait for 4 to 8 weeks before adding a new agent, and control for 6 months before tapering. And once you have a control for 6 months, then only think of tapering. Beautiful chart given by, again, Dr. John Dart, where we used to use this chart for all the blood parameters and evaluation as the patients used to come, and put them into a chart so that we knew whether the patient was having any side effects or not. And behind the chart, actually, all the side effects were given. So we used to just carry this sheet in the clinics, and we would corroborate when the patients came, to see whether there were any side effects or not. And with each of these agents, there are side effects, which also has been reported in that beautiful paper on step ladder pattern. Now, there are several surgical modalities for peripheral ulcerative keratitis, such as superficial lamellar keratectomy, conjunctival resection, glue, amniotic membrane transplantation, and most of them have been covered beautifully by Vikas. So you can do superficial lamellar keratectomy in these cases. You can do conjunctival resection, and I'll just show you the videos on how you do it. So you measure about 4 millimeters, stain it with your calipers. So you go 4 millimeters behind, and 2 o'clock hours on each of the sides, and then dissect underneath the conjunctiva and remove this strip of tissue from the area which I showed you. So you would remove it 4 millimeters behind the area of the ulceration and 2 o'clock hours on either side. So this is your conjunctival resection. I think that any general ophthalmologist can also do, and this is the result. So first modality, surgical modality would be this. Now, this is just to show in a case where we had planned to do even a lamellar patch graft because of the thinning of the area which was ulcerated. We again did a conjunctival resection in this, and then we stenciled out the corneal patch graft on a drape which was plastic, and then we cut it down and we put it onto the corneal tissue, and again stenciled it out onto the corneal tissue because these peripheral grafts are difficult to fashion. And then we placed it there, used glue on the surface for edge to edge, and then used suture for surface apposition, and used sutures for with the help of 10-0 monofilament nylon sutures for edge to edge apposition. Now this is just to show the pre and the post-op picture of the same. You may need tissue adhesives. I didn't have a PUK with the glue, so I used this for showing you. Just put the cyanoacrylate glue and put the drape patch there. Put only one single blob of it. Don't put too much, because then otherwise everything will tend to come with it. Now, amniotic membrane transplantation can be done. This is a case where multi-layered AMG was planned, and this is again, I think Vikas showed a beautiful video, but this is a case of PUK. So you have to do conjunctival resection in this. I'll always like to combine conjunctival resection with glue or with patch graft or with amniotic membrane transplantation, because you don't want the vessels which have immunological mediators coming there. So this is a small piece of amniotic membrane which is sutured. This can be also glued, and then a larger piece which is placed over it. Then rehabilitative surgeries have to be done in the form of crescent patch, which I've also shown you. Sometimes I just want to show that you may think you need a patch graft, but you don't. So if you just remove that cyst which was present there, you can just do an edge-to-edge suturing in these cases, and that suffices, which sufficed in this case. So sometimes you can even get away with this. This is just to show that you can do a sutureless patch graft. So this is a small PUK which is present here, and this was fashioned with the help of the crescent blade. Again, a tunnel all around the tunnel was made, and then a small piece of tissue corneal tissue was taken, and then this was placed here and then glued again, and the IOCT helps you to see where your placement of the tissue is, which you can see otherwise also not a big deal, but if it is there, then you just tend to use it to assure yourself that the patch graft is placed in the correct place. And then of course you may have to do patch grafts such as this. I will not be showing you because beautifully these have been already shown by Vikas. So you can do patch grafts of PUKs such as like this, and sometimes you have to do crescent grafts. Now, we did a large series of over 150 eyes, and this was a thesis of our MD student where we looked at our cohort and we looked at all these cases prospectively, and this is case from one of that area. We've all done crescent patch grafts, and sometimes you have to do annular grafts for these cases, and this is a very bad case of Murren's ulcer which has perforated. A pregnant female who was bilaterally like this, and there was no no option but to address this with a large corneoscleral graft. So these cases can be very difficult, but patient from TLPR bilaterally became with a visual acuity of 6/60 and 6/36. So the patient from blindness category moved to a category where she was ambulatory, and this is the post-op picture of the same. So this is the last video that I will show you, only for the reason of the technique being a little different. The necrotic tissue of the overlying PUK is removed, and this is followed by placing a Visilon over it. Now, if you place Visilon, it is very much like the way people see for lighthouses. So you place, after placing Visilon, you place the corneoscleral rim here, and you can actually trace out with the help of the gentian violet, again cut it the way that I showed you earlier, and then subsequently this can be glued and as well as sutured. So your suturing also becomes a lot easier after you place it with the glue, because then the tissue doesn't tend to move. And then the synechiae can be removed, and then sutures can be again reinforced. So again, this is true. Sometimes even after doing this, you have a melt, recurrent melt, such as here. In those cases, you may have to again control it with the help of the cyanoacrylate glue. And you can have Murren's ulcer. This is the last case that I wish to share. Left eye, severe damage due to Murren's, and right eye again melt. So this case was started on mycophenolate and cyclosporin. And this is the left eye. There was a desmetocele there peeping here, and a large corneoscleral graft has been done. Then there was a persistent epithelial defect in the corneoscleral graft also, which had to be dealt with the amniotic membrane transplantation. On the other eye, again, infliximab had to be started because there was a perforation there. And this is post-operative day 2 after conjunctival excision and infliximab, and this is the condition of the patient now. So to summarize, cases of PUK need to be given medical therapy concomitantly. It could be antibiotics, steroids, or immunosuppressive agents. Surgery is undertaken for tectonic purposes to enforce the area of thinning or perforation, and vigilance is required about recurrence of the disease in the post-operative period, because once a PUK is always lifelong a PUK, so you cannot leave it like that over there. So I would like to acknowledge Dr. John Dart, from wherein I learned the principles of immunosuppression and management of PUK, and thank you very much for your kind attention.